I'd like to echo Jonathan's words. I'd like to thank you all for being here today because it really reflects a thirst for knowledge and understanding about brain tumours, which some of you may have, some of your loved ones may have, or some of you are tightly involved in the support of people with brain tumours. I think it's actually an exciting time for brain tumours, and I'll touch on that during my talk, but my talk's a big talk. My brief is to give an overview on current clinical care and research on brain tumours. Now, I've got about half an hour to give this talk, and there's no way I can possibly cover a fraction of what I'm meant to, but hopefully we'll just touch on some key points. So first of all, I'm going to be very basic, and I'm sure you all know what a brain tumour is, but let's start at the very beginning. A brain tumour, to put it very simply, is a mass of abnormal cells either within the brain or surrounding the brain. We generally divide brain tumours into primary tumours, which may arise from the brain itself, and those primary tumours may be either benign or malignant. Sometimes tumours may be secondary, which is just a fancy way for saying that they've spread from elsewhere in the body and lodged in the brain. There are many, many different types of tumour, but we're going to concentrate today on my talk mainly on the primary tumours, just for the sake of brevity and clarity. Now, when I think about how many tumours there are, it gets bewildering. The World Health Organization has helped provide a bit of insight and clarity. It's created a classification scheme of brain tumours, but again, it can be completely bewildering. So if we look at some of the classifications of brain tumour, this is the sort of table that gives medical students nightmares. Gave me nightmares when I was a medical student. You can see that there are so many brain tumours. Epithelioid hemangioendothelioma. Gosh, mouthfuls. So to make it just a little bit simpler, we generally grade tumours. And tumour grading is really a form of shorthand. It's a form of shorthand as to how invasive or problematic a tumour can be. We generally grade them from grade 1 through to grade 4. Grade 1 tumours include meningiomas, which are the most common type of brain tumour, acoustic neuromas, pilocytic astrocytomas. There are so many difficult words in brain tumours. We have grade 2 tumours, which can include oligodendrogliomas and diffuse astrocytomas, grade 3 tumours, and then also grade 4 tumours. And grade 4 tumours are amongst the most challenging to treat because often they're the most invasive, but they can also be incredibly rewarding. And glioblastoma multiforme, or GBM, is the most common grade 4 tumour that we see. Jai's interested in the front. It's good to see. I'm going to concentrate again a little bit more on the malignant gliomas, that is, the grade 3 and the grade 4 tumours today, just to make it easy. Now, when we talk about brain tumours, how common are they? This is a very messy pie graph. This is data from the World Health Organization, so it talks about tumours worldwide rather than just in Australia, so there's a bit of a skew towards tumours which aren't quite as common here, but it does reflect the relative frequency of brain tumours. We can see that there are big pie segments for lung tumours and breast tumours and colorectal tumours, but brain tumours are only a fraction of 1.8% of the whole pie. And because they're so uncommon, it does make it difficult to create a voice in the media and in the community for those with brain tumours. But even though brain tumours are incredibly rare, I'll get to that in a second, there are many different subtypes of brain tumour. The most common is the meningioma, which I talked about before. GBM, or the glioblastoma, the grade 4 tumour, is usually the next most common. But even though they're very, very rare tumours, and in New South Wales, roughly about 250 to 300 GBMs are diagnosed each year, unfortunately the majority are men. Even though it's rare, the effect is profound. I think all of us have had some close contact with people with brain tumours, and we understand that brain tumours can affect a person's psyche. They can affect a person's relationships, insight into their condition, judgment in life, their mood, and even their memory. My memory's bad at times too. Not to mention specific neurological problems, weakness, problems with thinking, arithmetic, problems with vision and hearing. So brain tumours, although they're uncommon, they have a profound effect. So how do we find brain tumours? How do they spring up? All of you have your own story about brain tumours, but let's talk about how they can be discovered. One of the most common ways a brain tumour is discovered is through headache. Headache because there is quite simply a lump within the skull that raises the pressure within the skull and the brain. Sometimes seizures can occur. Seizures can either involve twitching of one limb or generalised seizures where one loses consciousness and the whole body twitches and jerks. Tumours can come to light because weakness develops in either the arm or the leg or the face, or occasionally speech problems, problems with vision, or confusion and personality disturbance. Much more commonly today, tumours are being found by chance. Just in the last few years, the federal government's changed the way that MRIs of the brain are funded, and GPs can order MRIs just for headache. Okay, and that's actually, at least in my anecdotal experience, led to a rise of tumours discovered before they actually cause symptoms. So, we've had some suspicion that something not right, so what happens next? Well, a CT is usually the first port of call. It's often ordered by the general practitioner or the emergency department, and a CT is a great test. It's quick, it's easy, it's good information, but it by no means tells the whole story. A CT is just a way of using X-rays to build up a two-dimensional and a three-dimensional concept of the brain. Here, for instance, we have a horizontal slice through the brain. The white around the outside represents the skull, and the grey material on the inside represents the brain. And one can appreciate, if I can get an arrow up, that there is something which is different on one side compared with the other side. There's an asymmetry, so we know that there's something not quite right going on. So what now? What's the next step? Well, an MRI is usually the next step. An MRI is a very good test. It can take a little bit of time to perform, and we have to wheel you into a tunnel, and people with claustrophobia or who may be a little bit confused sometimes can't cope with an MRI very well, but it gives us much more information. It allows a greater degree of planning because it tells us what's going on in the brain, what structures may be involved, and what we may need to do. What's next? Occasionally special MRIs are needed. Functional MRIs can be performed, which help show us where the language centres of the brain are. Sometimes we might ask people to be in an MRI for an hour or two and speak to the radiologist so we can work out exactly where their expressive and receptive centres for language are. Sometimes we'll map out fibre tracks indicating where the movement pathways of the brain are. It can be crucial for us to know these bits of information if we're planning surgery. Sometimes we might do magnetic resonance spectroscopy, which is where the molecular characteristics of the tumour are investigated through the MRI, so we can get an idea if the cells in what we think is the tumour, if the cells are rapidly turning over, or whether there's cell death going on, or whether we're completely on the wrong track. There's a new test called PET, positron emission tomography, which doesn't really have a tightly defined role yet, but is a way of investigating the metabolism of tumours and may have a future role to play either in the diagnosis of tumours or, more importantly, down the track whether tumours are active or whether there's pseudo-progression, which I'll talk about a little bit later on. So at this point in the journey, we've usually done some tests. We've had some suspicion that something has gone on, but there are lots of questions which remain to be answered. But we don't just do the tests in isolation. Whilst the tests are going on, we do start some treatment. We might start some Dexamethasone, which I'll talk about. We might start some Anticonvulsants. We might stop blood thinning medication, and we might talk about work and whether one can continue to drive. So Dexamethasone. Everybody who's had a tumour has had some contact with Dexamethasone. Some people love it, some people hate it. But it's the most common drug that we give to patients with brain tumours. It's a crucial drug, it's an important drug, because what it does is it sucks the swelling and the edema, fancy medical word for swelling, it sucks that away from the brain surrounding the tumour. And if the pressure inside the brain is raised or elevated, dexamethasone can be incredibly useful to bring that pressure down. It can be life-saving. Dexamethasone is a very potent steroid, but there are problems with it. In the short term, when we give steroids, you can get sleeplessness, you can get very agitated, you can get pressured in your thinking and your thoughts, you can get a bit of paranoia, potentially. Dexamethasone acts on parts of the brain to stimulate your appetite. You can get weight gain, you can get fluid retention. If you take it for a very long time, you can get diabetes, cataracts, thinning of the muscle, bone and skin, and even vulnerability to infection. He's a very cute young man. He's only 2. I'm surprised that he's lasted this long. It's good for his age, Dale. So dexamethasone is a very necessary, it's a very useful drug, but we really can't stay on it for long. Anticonvulsants. There are so many different types of anticonvulsants. The common ones that we might use when somebody comes to us with a seizure could be Dilantin or could be Keppra. The medical terms for those are phenytoin and levetiracetam. There are multiple side effects with anticonvulsants, so we should only give them if necessary. Some of you in the audience will be on anticonvulsants and can recognise the dizziness, the tiredness, the fuzzy thinking that the anticonvulsants can cause. One thing which we're very mindful of is whether the anticonvulsants or unnecessary medications in general can affect some of the other treatments that we may need to give for brain tumours, such as the chemotherapy. And all medications can potentially have an effect on the liver and the bone marrow, and anticonvulsants, especially phenytoin, is certainly prone to this. So again, anticonvulsants may be necessary, but we should never give them without good cause. So now we've done some more investigations. We've got our information with the CT, the MRI, the special MRI if necessary. We may have started the steroids. Patient may be feeling better, but what's next? How do we treat brain tumours? Well, before I talk about specifics, I'm sure you've heard the adage, brain tumours are a journey. And you'll meet many people on your path through this journey. Initially, the neurosurgeon is really the first specialist that you might meet. Then the radiation oncologist and the medical oncologist. The GP is crucial as a traffic director. The neuropathologist is crucial to tell us exactly what's going on. And then a care coordinator or a clinical nurse can be crucial to act as a traffic director once more for a patient's care. Notice that in the very centre of this tree, I talk not just about the patient, but the family as well, because this is a journey that doesn't affect one person, okay? It's a journey that affects the entire family. But I'm a neurosurgeon, and I'm usually the first port of call for somebody with a brain tumour. So how do we treat brain tumours with surgery? Well, surgery is still the best initial treatment for most tumours. I used to love The Far Side. I'm so disappointed that Gary Larson gave it up, but anyway. So surgery is a way of getting the tumour so that we can look at it under the microscope, so we know what's going on, so we have a diagnosis. Remember that table with dozens and dozens of different tumour types? Well, we need to whittle those tumour types down to one. We need to know which tumour is there. But more important, or as well as diagnosis, we need to physically remove as much tumour as is safe. There's been a huge philosophical shift over the last 20 years from minimal surgery or biopsy to the maximum resection, which is safe. And for some tumours, for the benign brain tumours, a cure is possible with surgery alone. Benign primary brain tumours, such as meningioma, such as acoustic neuromas, such as pilocytic astrocytomas, they can potentially be cured by surgery alone. Of course, the location of the tumour is critical. The structures surrounding the tumour are the main hurdles as to whether surgery is going to be able to achieve taking all the tumour out if it's benign. For malignant tumours, and again this is the real focus of my talk this morning, we talk about gross total resection. We talk about transforming an MRI like this into an MRI like this. That is, we want to remove all the abnormal looking brain. But of course, gross total resection is a little bit of a misnomer, because we know that with malignant tumours, often invariably there are microscopic tendrils which have extended beyond what we see on the MRI scan. So again, the location of the tumour and the surrounding structures are critical, and we talk about gross total resection, but surgery is not sufficient by itself for tumours that are malignant, for the grade 3s, for the grade 4s. But how do we do surgery? Well, the aim is always to safely differentiate the normal brain from the tumour. I'm biased. I think the brain is beautiful. I actually tell my medical students to repeat it as a mantra. They hate me. So we do this through a few techniques. We use stereotactic navigation. We use fluorescent compounds such as 5-ALA. I'll talk about these in a moment. We use intraoperative MRI, and occasionally we may use awake craniotomy. Stereotactic navigation is a way of using an MRI that has been obtained before the surgery and programming it into a GPS system for surgery so that we know exactly where we are by using in effect, a magic wand during surgery. Intraoperative MRI, we have a centre in Sydney at RPA that uses intraoperative MRI. So during surgery, a limited MRI can be obtained so we can see to what degree the surgery has achieved its aim of gross total resection. And for some situations, an awake craniotomy or awake brain surgery may be useful for those tumours that may be incredibly close to very important bits of the brain. At Prince of Wales, we use intraoperative fluorescence, where we give glialan, which is 5-aminolevulanic acid, to patients before their surgery. This compound passes to parts of the brain which are actively involved with tumour. This is an operation performed by a now retired colleague, Dr Bernard Kwok, and one can see that when we shift from the standard light to the fluorescent light, we see some orange tumour. And it's immediately apparent that some parts of the brain that may appear identical under the normal microscope when we're operating, when we give this fluorescent material, it shines like a beacon. So we know that that brain's involved. It's just another way for us to differentiate between tumour brain and normal brain. As I said, the only intent of all our surgery is to discriminate between the tumour brain and the normal brain as safely as is possible. So surgery is always a delicate affair. We have to, on one hand, have our priority of making sure that we cause no harm, that we don't cause any neurological problems or damage, and on the other hand, we want a good resection because we know that that's important for most malignant brain tumours. After surgery, most people will be in hospital for somewhere between 2 days to a week. Sometimes, if there is weakness before or after surgery, there may be the need for rehabilitation or other symptom support, and hospitalisation may be longer. But our main concern throughout this whole process is patient safety, physical safety, cognitive safety, and emotional safety. We all want everybody to get home as soon as possible, but as safely as possible. So now we've had the surgery. Touch wood, surgery's gone well. We've achieved a gross total resection. We're happy that you look strong and you don't have any neurological problems. Well, what's the next step? Well, we hand over to our pathology colleagues. And tissue is sent at the time of surgery. Now, this can be a very frustrating period from the time of surgery to the time of the full diagnosis. But it's a necessary halt in things, because the tissue, the brain tumour tissue that's removed at surgery, needs to be processed. So it needs to be soaked in alcohol, it needs to be stained with special chemicals, it needs to be looked at, of course, very carefully by the neuropathologist. Pathology, remember all those dozens of different types of tumour that I showed you at the beginning, pathology can be difficult to pin down. Occasionally, special immunohistochemical or molecular testing techniques may be needed, and as I say, waiting for the final result is always a little bit frustrating. But as you can see, it can be difficult to differentiate things when you're looking at patterns down the microscope, which aren't necessarily straightforward. I applaud our neuropathologists. They do an amazing job. But hopefully now we've got an answer. We know what the brain tumour is. We've had surgery. The next step in the path is to hand over to our radiation oncology colleagues. Radiotherapy, or radiation in general, is simply transmission of ionising radiation delivered to the tumour and the surrounding brain. And there's a difference between radiotherapy and radiosurgery, and I'm sure my colleagues will talk about this later today. But radiation has as its chief goal the aim of damaging the cell. Okay? Now this is a rather busy picture. This is a picture of the cell cycle. And what it is, the cell cycle is really a cycle of growth and division. So cells which are actively replicating pass through this cycle. Cells which are static, which aren't replicating, are at rest over in this little corner just here. Radiotherapy exploits the fact that tumours are replicating much more quickly than the surrounding brain. Radiotherapy exploits that by targeting the cells when they're replicating and damaging the DNA of those cells. And chemotherapy often works in a very similar way. So radiotherapy exploits that biological difference between tumour cells that are moving and dividing very quickly versus brain cells which are relatively static. Radiotherapy entails multiple small doses of radiation over roughly 6 weeks. Sometimes that schedule may be changed if a patient is a little bit older, hypofractionation. And the brain is generally less affected than the tumour, just because of that cell cycle. But radiation can, of course, have side effects. There can be tiredness, there can be hair loss, there can be headache, there can be longer-term issues, such as problems with cognition down the track, or even radiation necrosis. Radiosurgery, which some of you may have heard of, is again the transmission of radiation to the tumour, but it's very different because this radiation is high-dose radiation and it's highly focused. So all the tissue at the focus of this type of radiation gets affected. Effectively, it gets killed. And radiosurgery is a single dose treatment. It's a single zap as opposed to the radiotherapy, which is a schedule over 6 weeks. And radiosurgery can be incredibly useful, especially for benign tumours or some secondary tumours, because it sterilises those tumours. Once the radiation is complete, okay, hand in hand with the radiation often is chemotherapy. Temodal is one of the most common types of chemotherapy for brain tumours, which we're using at the moment. Temodal, the full name is Timmons Olamide, which is a bit of a mouthful. It's an alkylating agent. All that means is it interferes with DNA replication. Again, this type of chemotherapy attacks those cells which are more actively dividing and growing. This has been available since roughly the last 15 years, and I'll talk more about it in a few minutes because I think it's profoundly exciting, and it's rapidly become a standard of care just in the last decade. And most Stupp protocol regimens now, fancy way of saying most of the ways in which we give chemotherapy and radiation involve daily Temodal during the radiation treatment, and then after treatment about 6 cycles of Temodal, where we give Temodal for 5 days in every 4 weeks. And our aim is to keep this picture, which has gone from a tumour on the left to a black hole on the right, and to keep that brain scan on the right stable over time. And how do we do that? Well, we then progress to the phase of surveillance. And to do that, we do regular MRIs. We may do them every 3 months. Some people would even do them every 2 months. If a change is seen on the MRI, well then, of course, we reevaluate how we're treating a patient with a brain tumour. Sometimes we need to differentiate if there's true growth in a tumour versus just the appearance of growth on the MRI, what we call pseudo-progression, which can be a bit of a tricky thing to determine. Let me just talk about research just for a few minutes. Let's look at the history of research with tumours. Well, GBMs. If we look at GBMs historically, the survival was pretty limited. Before the real growth in treatment of GBMs over the last 15 years, the average survival was 9 months. The usual treatment was surgery, where a biopsy was obtained. It wasn't a gross total resection, okay? There was radiation, which usually wasn't as targeted as perhaps it is today. And there was a real sense of nihilism about treating this disease. For 30 years, this 9 months mean survival didn't really change. But just in the last decade and a half, this has profoundly changed. And this is why I think it's an exciting time for brain tumours right now. If we look at Temodal, which I think is one of the biggest game changers, Malcolm Stevens from Aston University in Birmingham looked at this CCRG 81045 molecule. That was its name before it was called Timmons Olamide. There were some phase 1 trials in the 80s and the 90s, and then a big phase 2 trial in 1997, until we had the STUP protocol published in the New England Journal of Medicine in 2005. And median survival of GBMs has effectively doubled. And that's a profound increase, and that's incredibly exciting. Here's a picture in the middle of Malcolm Stevens. He looks like one of our hipster baristas from today. What's old is new again. So Timmons Olamide is probably one of the first biggest game changers for research into GBMs. And it enabled the development of molecular and genetic research ideas. Now, I don't mean it enabled it directly, but I think it changed the ecosystem and the ecology of GBM research. It injected a little bit more hope and enthusiasm into the whole field, which for decades was rife with, as I said, a sense of nihilism. But I think that hope continues today. So most chemotherapy and radiotherapy really exploits changes in that cell cycle to have its effect. But now we have a better understanding of some of the pathways which actually lead to GBMs at the molecular level, and we have these rather busy diagrams of molecular targets and things that we can try and alter at every stage of the molecular pathway misadventure. And I think we're changing from the shotgun treatment approach to GBMs and brain tumours in general to a more targeted approach, and that's exciting. And targeted therapy usually has specific targets in the whole cascade of cellular misadventures that we can that lead to promote brain tumour growth. And by targeting these specific areas, there's been great encouragement in certain subtypes of GBM. And I think we're now recognising much more readily that GBM, which used to be a huge, big tumour label, really consists of many, many types of tumour that we can really affect very differently. Radiation's improved, not just chemotherapy. Improved collimation, IMRT, improved targeting of the radiation to where it's needed with fewer late side effects. And in the future, there may be radiation sensitizers which will add to the efficacy of radiation. Because the radiation oncologists and the chemo doctors have lifted their game, neurosurgeons have been forced to lift our game with better microsurgical techniques, with much better aids in surgery. I don't know why I've got that extra E there, I apologise. With navigation and the intraoperative MRI and the fluorescence. And we're much better at looking at our results and being self-critical and saying, well, we should have done a better job there, we need to. And I think it's important that the ecosystem of brain tumours has changed. There's a much closer relationship between researchers, pathologists, oncologists, both medical and radiation, and neurosurgeons, and I put us down the bottom and researchers up the top because I think that's the way it should be. There has to be a marriage of research at the basic science and the clinical levels. If we look at clinical trials, there's a whole alphabet soup of trials that are going on at the moment. I can just get up to C and have a few trials up there. But if I look at the Australia and New Zealand Clinical Trials Registry, there are there are 44 trials which are involving GBMs. Many of those aren't active, but it just reflects the fact that there's so much enthusiasm for GBM research and brain tumour research at the moment. So what could be the future for brain tumour research? Well, again, I think changing from that shotgun strategy to the targeted strategy. Directed therapies that are individualised after analysis of each individual tumour. Vaccines, small molecules, looking at specific susceptibility to chemotherapy agents. But of course, research does have its issues. Funding is fickle. We are a very small slice of the pie. And I'm very glad that in this week, it's been very fortuitous in Brain Cancer Awareness Week that Kerry Bickmore has come up with her blue beanie to try to increase awareness, because that's what we all want. We want better education and awareness in the community. But let's just sum up a little bit of my talk and package it up. What does it mean to the patient out in the audience with a brain tumour? Well, I think it does mean a bit of hope. This is a very hopeful time for patients and families who have contact with brain tumours. All clinicians, and I think I speak without exception, all clinicians who are involved with brain tumours have passion and enthusiasm. Larger centres, as a rule, have that ecosystem that I was talking about. They have more resources and clinicians with a subspecialty interest in brain tumours and a greater research affiliation. And it's crucial to have access to clinical trials if appropriate, and to have access to basic science research, tissue banking and potential personal profiling. Because what we want, of course, all of us, is to really have satellites which are contributing to improving outcomes for patients and their families. And I think dedicated neuro-oncology centres are the way to do that. We rationalise resources and care. So, if you or your loved one has a brain tumour, find a clinician who is passionate and everything will flow from there. Thank you.